Thank you for introducing me. The session is very interesting for me because I have a lot of alcohol use disorder patients, and among the majority of them have also has alcoholic liver disease. And I try to communicate with the hepatologist in my hospital, but has some difficulty. So today, hopefully, I will present my presentation, and hopefully, it will help you and me for communication. This is the content of my presentation, background, and definition of alcoholism and alcohol treatment. It will be maybe a little bit overlap with the first presenter. And the other part, I will introduce the efficacy of the pre and post-LT alcohol treatment. And last of the session, I will introduce my research result. In this slide, I would like to say the prevalence of alcohol use disorder and treatment-seeking rate of alcohol use disorder. You can see the left graph. This is the graph for the 1-year prevalence of alcohol use disorder in Korea. You can see that among 30s, different from other age group, the rate of alcohol use disorder in female is higher than male. This is the first phenomenon observed in Korea. And you can see the right graph. This is a treatment-seeking rate regarding the alcoholic liver disease. This is for the alcoholic liver cirrhosis. You can see the 30s and 20s. Among 20s, the number of the patients who treat alcoholic liver cirrhosis is more higher than in female. And 30s is a very similar degree of the number of the patient. Also, this is the first phenomenon observed in Korea recently. So I can say that new demand for liver transplantation will increase in young women. In this slide, I would say why we need to deal with the alcoholic liver disease and alcohol use disorder condition in clinical field. I met a lot of alcohol use disorder patients with the diagnosis of alcoholic liver disease. Every time I met them, I said that I will deliver you good news and bad news. And bad news is your liver condition is cross the river. But the good news is there's a definite way to you stay safe long. The definite way is the abstinence. It is good news. And around 20% of the post-LT patients relapse to heavy drinking, also which is related to the consequence of failure and increased mortality. So I can say that essential factor for post-LT survival is managing alcohol problem. Now, this is the explanation of the definition of alcohol use disorder and related consequence. Left picture shows the reward circuit involved in the occurrence of alcohol use disorder, composed of prefrontal cortex and basal ganglia and amygdala. And right graph shows the risk of the alcoholic liver disease increase as the amount of alcohol consumes increase. That is, alcohol use disorder is mental behavioral disease, but it can cause a variety of the fatal physical disease. Therefore, integrated mental and physical treatment considering various factors is required. This is a summarized explanation of a concept of alcohol use disorder considering the treatment. Alcohol use disorder is a primary disease. The primary disease means that it has their own unique pathophysiology and also has their treatment modality. And second principle is brain disease. It's very complicated. And third is a chronic disease, repeating deterioration and recovery. And fourth is a serious physical disease condition like the alcoholic liver disease we discussed today. And last is a complex disease composed of bio, psycho, social factor. So the treatment guideline is according to this kind of the conceptualization of alcohol use disorder. The principal of the treatment is firstly, continuously for a long time, because alcohol use disorder is a lifelong disease condition. And second is frequently see the patient even short time. Sometimes I see the patient 3 times a week in the initial stage, and once a week, at least twice a month. In my clinic, alcohol liver disease patients tell me, my internal medicine physician asked me just visit within 3 months or 4 months. Why do you ask me to visit so many times in your clinic? So I would like to say today, ask you to ask the patient visit more times, not 3 months or 4 months. And 3 approach to the therapy is composed of medication and counseling and community social support. This is for the medication. I think that I just add some explanation because it's kind of a little bit overlap from the previous speaker. And we have 2 approved options, naltrexone and acamprosate. Naltrexone is kind of blocking the positive reinforcement. So it applied to the early stage of the addiction, but it has some side effect for the hepatotoxicity. So we need to careful monitoring of a liver function test. Acamprosate is, the goal is to maintain abstinence. It's a safe on liver function, but it's a little bit less effective efficacy compared to the naltrexone. This is a novel agent, not approvable in Korea, but nalmefene and baclofen is approved in European country. But in Korea, some psychiatrists use topiramate, gabapentin, and aripiprazole based on their experience. I'd like to move to the psychosocial treatment. The good treatment consists of clinical and biological treatment, and psychological treatment, and social needs response treatment. And we also have there is evidence-based psychosocial treatment, medical management, and motivational interviewing, and cognitive behavior therapy, and mutual support like Alcoholics Anonymous or 12-step facilitation therapy. This is respectively for the information knowledge and compliance, motivation, social skill, and support. And the alcohol treatment is composed of 3 different factors: mental health and addictive behavior and rehabilitation. Mental health is related to the emotion, stress, relationship, and addictive behavior is related to the motivation, behavior, and relapse prevention. And thirdly, rehabilitation is related to the housing, living, job, and welfare support. I would like to add some explanation on medical management. And the large nationwide randomized controlled trial conducted in the United States, and the result showed the most cost-benefit treatment option is medical management plus anti-craving agent by not specialized psychiatrists, but provided by usual physician like family physician or internal medicine physician or even surgeon. So medical management is consists of these different 6 components. First is a cognitive reconstructing and providing realistic information and motivational interviewing and take-home reading material for the maintain abstinence and tailoring psychosocial intervention like coping strategy for the high-risk situation. And last one is the most important thing, I think, following a patient by phone call, something like that, who miss appointment. From this slide, I will introduce the study results regarding the pre- and post-alcohol treatment for alcohol liver disease related to the LT patient. I think in the previous session, the speaker mentioned about that the 6 months rule is no longer gold standard. So I think that therefore the pre and post evaluation and treatment for the alcohol problem are most emphasized. So this The risk assessment system include HERAL and HRRA and SIPAT and MAPS. So this evaluation system include the seriousness of alcohol use disorder and risk protective factor for relapse, like temperament and family history and family social support, and comorbid psychiatric symptoms like depression, anxiety, stress, and illness response. So we evaluate this kind of risk factor. We can tackle this risk factor. We can make the person who survive longer. In this slide, I'll present some results of the program dealing with stress and anxiety that trigger drinking among the LT patient. The CBT, or mindful-based stress reduction therapy, facilitate the adaptation to the stress. The stress is provoked drinking, so it may be effective. And stress management relaxation training, like SMART, also is very effective in ESLD patient awaiting liver transplantation. And MET is a motivation enhancement therapy based on the motivational interviewing is also can be beneficial for the pre-LT population. And group CBT during the waiting list period is also might be shown the promising effect. And recently, a lot of digital therapy like technology-based counseling approach might be effective, or a lot of this program introducing. And next, I would like to summarize the result of the program effectiveness in preventing relapse of risk drinking after liver transplantation. And more comprehensive and intensive intervention are needed because alcohol relapse non-adherence can induce direct consequence for the allograft and overall survival. And randomized controlled trial evaluating the effectiveness 1 year post-LT behavioral contract. Behavioral contract is like the physician and the patient and the family contract. I own drinking, like some document write down, but unfortunately is a lack of the evidence. And the other, post-LT addiction therapy and Alcoholics Anonymous on post-LT relapse in recipient with ALD found such combination therapy effective in reducing post-LT relapse. But they found that only around 28% of LT patients participate in such AA group. And AA group accessibility in Korea are very limited, especially. And in this slide, I would like to introduce the result of the special multidisciplinary unit in the transplantation center. An Italian clinician proposed the need for implementation of alcohol addiction unit within the transplantation center. This model includes the multidisciplinary team with board certified physician and physician in training, and psychologists with expertise in alcoholism, and hepatologists and neuroscience would simultaneously offer the medical and pharmacological treatment and behavior therapy through the continuum of LT care. And the other program is the adherence treatment program, Maestro. This program also showed 5 times greater in the intervention group than in the control group. From this slide, I'll introduce the 2 of my research results. Both are not conducted in addiction specialized setting, so I can say that it can be useful information for you. I developed a web-based screening brief intervention program that takes about 10 minutes and conducted RCT to verify the effectiveness among the general public with high-risk drinking. And the table showed that the level of drinking problem measured by OD score and binge drinking and the alcohol consumption by measure the timeline follow-up follow back decreased over the time in the intervention group compared to the control group. This is the second study, the result. This is an RCT study that verified the effect of one session brief intervention program for the high-risk drinking patient with alcoholic liver disease in the internal medicine setting. This trial was conducted in hepatology outpatient setting, and 390 patients were enrolled. This is the result. Intervention group, we provide a single session lasting approximately 15 minutes, provided by trained psychologists. The content of the brief intervention is encouraging the patient, and then we, after the session, we encourage the patient by phone call a week later. And control group, for the control group, we provide the A4 size double-sided brochure, and the physician briefly explain the just screening result. And you can see the result, pre and post-intervention, and control group and intervention group. You can see the both group show the significantly reduction in the audit score. But in the time group interaction, you can see the very little significant difference. The intervention group is a little bit of the large degree of the change. So I can say the implication of this study, the result indicate that alcohol consumption can be reduced through a simple intervention for outpatient in internal medicine clinic who needed to stop drinking or reduce the use of alcohol. And considering the medical field situation in Korea, I think they're very similar in other countries. A brief intervention provided by trained counselor or providing a simple brochure will be helpful to stop reduce alcohol intake will be the strategy. And considering the effect of a control group, the doctor's advice to reduce alcohol consumption might be an important component in decreasing alcohol intake at average visit by motivational enhancing way. This is the final slide. I think that the overall prevalence of alcohol use disorder is decreasing, but rate of alcohol use disorder and alcoholic liver disease increase in certain age group. That is, demand for the alcohol LT for the alcoholic liver disease will be increasing. And the evaluation of the treatment of alcohol use disorder among alcohol liver disease LT patients are crucial factor for the prognosis of the liver transplantation. And there were also, we have evidence-based alcohol program for peri-alcohol liver transplantation. So cooperation between physician and psychiatrist is very important. It is necessary to develop a liver transplantation center model in which internal medicine and psychiatrist and surgeon and multidisciplinary team cooperated and to study its effectiveness. Thank you.